Good evening, everybody. Thank you for joining and learning about chronic pain. We're going to go from basically the neurological aspect of pain all the way through an acute injury, all the way to chronic issues, and kind of what's going on beneath the surface. So today I'd like to talk about living and embracing and empowering you living with that chronic pain. This is a topic near and dear to me. I won't tell you my story, but well, we certainly don't have time for it. But again, I'm very passionate about this topic. It's been a huge part of my life, and it's certainly shaped me and it's shaped me as a clinician. I want to give a warm shout out to our work strategies division, which is our kind of like our work comp division. So I was on their task force a few years ago with putting together pain resources for both clinicians and patients alike. So I want to give you a special acknowledgement to Dave Hoyle, Dave Raptosh, Kristen Lane, Neetu Trivedi, Bill Beck, Jamie Bursick, and Paige Kessel that was on that team. Thank you guys so much for that opportunity. I learned so much from you guys. So what are our objectives today? Well, obviously talking about pain, what is the definition of it, the etiology of it? There are really three main types of pain classifications that we'll talk about: nociceptive, neuropathic, and nociplastic or neuroplastic pain. We'll describe how acute pain can manifest into chronic pain within those three main classifications, and at any one point in time, they can all be interacting together. We'll discuss some common orthopedic conditions. If we talk about pain and kind of the etiology behind it, it blends obviously into some of these conditions that we deal with. We'll talk about some common treatments associated with these painful conditions. Is it conservative treatment through physical therapy, or is it more pharmaceutical, surgery versus non-surgical? My main takeaway today is I want to empower you. I want you to take control of your pain. If you have pain, I want you to learn about it and be able to restore your quality of life. So what is the definition of pain? Well, the International Association for the Study of Pain defines it as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And if you look at that sensory and emotional experience, that's either with actual or potential tissue damage. That's pretty big there. If we're looking at pain, it's not just one system that's affected. It's really all systems. It's musculoskeletal or your somatosensory system, your central or your peripheral nervous system, your cardiovascular system, and your immune system. So just kind of going into an example here using an ice cube. We all have that, wrong ice cube. All that same experience of maybe holding an ice cube, what that feels like, what's going on once we touch an ice cube. So just to give a little bit of information about what's going on beneath the surface, there's a ton of receptors within our bodies. The mechanoreceptors are the big ones. We have Ruffini corpuscles. These are usually within your joints and your tissues, give you some insight about rotation, things like that. We have Pacinian corpuscles, which are more so giving feedback about compression or vibratory. These are usually found more so in your discs, in your meniscus, within your knees, just in the spine. We have the Golgi tendon organs. These usually work hand in hand with the muscular receptors, the muscle spindles, again, giving feedback, length tension relationships within that muscle, letting you know if you're on tension, if you're on stretch, things like that. The big thing that we're going to talk today is those free nerve endings that get in the way and give us all this feedback to the brain of what's going on, right? So the free nerve endings are the big problem here when we do experience pain. Muscle spindles, again, these are going to be within the actual muscles themselves. They're going to give you some feedback on, that length or tension again. And then we have extrateroceptors. These are going to be within the skin. These are usually, light touch, dull touch, sharp, dull, hot, cold, things like that. All right, so if we have an ice cube and we put it on the back of our hand, right, what is exactly happening? Well, that ice hits the skin. It's going to set off some of those mechanoreceptors, extrateroceptors. We're going to have some feedback going back to the brain, right? There's usually a three neuron relay that's going on underneath the skin. So basically, first, these nociceptors within your skin, within within your body are getting elicited. They're kind of talking at this point, and they might be telling your brain, is it something that feels pleasant? Is it something that's neutral, or is it noxious? Something that's not good for the system. And in this sense, if it's something noxious, pain is not punishment. Pain is a protective mechanism, right? We all know that experience of that hot stovetop. I remember my grandmother telling me, don't touch it, even though that the gold color went away, it's still hot. Well, I learned very quick that day, right? This happens within nanoseconds. The transmission is super, super quick, right? So that ice is hitting the skin. It's giving that feedback to the brain, right? It's hitting those initial receptors, those free nerve endings that are in the area that elicit pain to the body. There are silent ones that can be in the area that are just waiting to be turned on, right? So if we had the ice cube, we put it on the back of the hand, you feel that sensation, right? Within a few seconds, 10 seconds, 15 seconds, that sensation can grow, right? These are the free nerve endings that are starting to get elicited that are silent. If we take the ice cube away at that point, we've taken away the noxious stimuli, right? The body restores very quickly. We leave that ice cube on there, that's where we start to see actual issues, right? If we have tissue damage or if we have changes on the cellular level, this is where we start to see that it's going to go from a nociceptive pain response to then the next, which is neuropathic, and I'll get into that in a second. But what's happening is, as that is then getting leaked from those free nerve endings into those peripheral nerves, it's going into more of a main nerve, right? This nerve then goes up into the spinal column. It gets processed by something called the dorsal horn in the spine. And then it goes up the spinal thalamic tract, it's called, up towards the brainstem and into the brain, where it then gets integrated, gets processed by certain areas within the brain, whether that be the thalamus, the hypothalamus, the primary and secondary cortex, sensory cortex. And there's other areas of the brain that get elicited, but I'm not going to go into detail. Mostly, and there's a ton of fibers that are going to give us feedback, but mostly as far as pain goes, it's the A delta and C fibers that provide information to the brain. Thermochemical and mechanical are a big one, right? So the brain then scrutinizes it. This is good feelings, this is bad feelings, this is neutral feelings, right? And if it's pain, we're going to have a cascade of events. So big takeaway. With pain, sometimes we can't avoid it. We can't avoid pain, but what we can do is we can avoid suffering if we know the tools, right? So we're going to go beyond the acute issue, right? We have the ice cube on there. It's now growing, right? So if we have something that's going from acute inflammation into more chronic inflammation, we're going beyond 10 days, 3 weeks, into a month. Chronic would be 3 months to 6 months or longer, right? So if that's happening, we can go into an aspect of neuropathic pain, right? I'm just going to give you a little bit of the nociceptive pain. It's local, it's noxious stimuli, it activates this free nerve endings. It's basically everything that I just mentioned. The only thing that I didn't mention is the cascade, right? So we all know that feeling. If we have pain, sometimes we even feel it down into our gut. It starts to go all over the body. We have different nervous systems that are being set off, right? The sympathetic nervous system is the big one. This is kind of our adrenaline rush, that fight or flight response, right? We get that quick, shallow breathing that starts to happen. We get that heart rate racing, right? So all these things start to get activated. The room is on fire, get out, right? So this is neuropathic. Once it grows so much that the free nerve endings get elicited within the peripheral nervous system that then goes to the spinal cord, there are further free nerve endings within the spinal cord that can get activated, right? And so, for example, I had a patient, he had a laceration on his third digit of his index finger. He was trying to get back to work as a carpenter. He was using his hand, trying to use a screwdriver. It was getting really painful through the finger. The pain was growing into the hand, and now it got to a point where it was going all the way up the arm towards the neck, right? That's more of a neuropathic pain. This is when it starts to become a problem, right? We can still work with this. In nociceptive pain and neuropathic pain, we can still work with this, right? It's when we get to the next section that I'll talk about is where it gets really difficult to treat. We're looking at more of a diffuse area. Sometimes the pain can be local or focal and it can be reproduced. Sometimes it can't, right? And we have to then look at more neurodynamics to see where in the nerve that is being locked up and where the pain is actually coming from, right? And if we don't get out of this portion, we can then get integrated completely into the brain, where our brain is now giving back an output, right? So we just talked about nociceptive and neuropathic. These are more input, right? If I were to touch something, it goes up the arm to the brain, it gets integrated, gets processed. We're now at a point where the brain is taking over. The brain is telling you that you have pain. And again, you might not have tissue damage. You might not actually have an injury. You might be healed from an injury, but your brain is still telling you, I have a problem, right? This is where things really become an issue. It's really hard to treat people at this point because we're not just treating the hand, we're not treating the arm, we're now treating the brain and the arm, right? And the rest of the body. Our thoughts, feelings, and perceptions are going to directly affect our pain, really, right? Because our output, if you want to call it input, output, or ascending or descending, they're all kind of the same thing. Feed forward or feed backward response. So these are all output issues. If you have an output issue, right, it's not going to make any sense at all. Pain could be all over the body. It can happen without even being touched, right, or being reproduced. Again, this is with an internal environment at this point. Our pain is kind of made up of something called saliency, which is kind of a programming, a mapping, right? And so within the mapping of our brain, if in our environment, we can quickly go from that room being on fire, right, to the whole house is on fire, everything's on fire, rather than it was just the couch that was on fire that you were standing next to and got burned on the hand, right? So it can become a huge issue. So what do we do with that? I just gave you a little bit of the old view here. This is like that 3 neuron relay that I talked about. The issue really is on the right-hand side. This is really what's going on when you do experience pain. It's not this quick, easy, just one thing to another. You have a cascade of events that happen. I kind of mentioned heart, I kind of mentioned lungs, I kind of mentioned gut immune response. All these different aspects get elicited. And a little bit of a closer view, I had stolen this from Lorimer Mosley, who's a pain neuroscience guru at this point. So I just want to give him some credit on those diagrams that he put out. As a little bit of a summary, just as nociceptive, neuropathic, and nociplastic pain, right? We want to work within that nociceptive or neuropathic because it gives us some information, right? We know kind of what's going on. We have tests that can reproduce things of what's going on, and then we can treat it. With nociplastic, it's going to be very tough to treat. These are going to be usually non-orthopedic issues that then come from orthopedic issues. I'll talk about that in a bit. But again, it can cascade into more like immune response type of issues. How do we get into the nociplastic pain? This is a very good diagram, actually, about what happens. So let's say we had an injury, right? We experienced that pain. If we don't have fear around that pain or we know what to expect, we can confront it and we can work on it and we can work on recovery, right? So I feel like the best example is a child as our resource here. We always learn the best from children. Ergonomics is number one. We learn best from 2 and 3-year-olds. They have perfect form for everything. But if you think of little Bobby, he falls, scrapes his knee, right? There's that delayed response. Like Bobby falls, he's bent over, he's holding his knee, he's looking at you, you're looking at Bobby, right? Bobby, are you okay? And there's that delayed response. It's like he's still processing what's going on, right? It's the fact that when he looks down at the knee, he sees his knee bleeding, boom, there's that reinforcement. Hey, I have a problem, right? The next time that he falls and scrapes his knee, he might not even injured it. It might not be bleeding at all. But because he had that experience beforehand, he's now more attuned. It's reinforced at this point. And as far as the neural network goes, we have what's called a synapse within our brain, within our bodies, that there's these little bridges that shoot chemicals across, right? So if you have an actual injury, you're going to have changes to those chemicals within your body. But those synapses come closer and closer the more that we reinforce them. right? So you have a quicker message that's then processed through the body. So the next time he may fall, he may not actually injure anything, but he had the experience beforehand. And again, he'll cry right away instead of a delayed response, even though there's nothing wrong, right? So again, that saliency or that programming is going to reinforce actually maladapting coping mechanisms, right? So people that may have maladapting coping mechanisms, there may be trauma in the past, bad experiences. There could be like emotional regulation issues. People just don't know how to deal with it, but they have that pain experience. And oftentimes we find that if there are comorbidities of, let's say, like depression, anxiety, we're going to start to see some pain catastrophizing, right? It's going to really get blown out of proportion. We usually see a lot of negative affect around this, and it just continues to create this cycle, right? So with that, it can magnify the pain experience a heck of a lot more, right? A good example is, let's say you're running, playing, having fun with some kids, right? You stub your toe on the coffee table. Man, it really hurt, but you're still laughing and having a good time. And then the pain may set in later, and then, kind of go through that recovery process. Well, let's say you're having the worst day of your life, you stub your toe on that same coffee table, your pain might be a 10 out of 10, right? You might go right into that pain catastrophize. What else could go wrong today, right? So once we go down that pathway of negativity, we can start to get into pain-related fears, right? We're giving that input and output system the wrong information, right? You might have an issue where you go to grab something and it kind of hurts. Well, it shouldn't be, right? So our input and output is starting to get affected. That's going to create fears. It's going to create behavioral changes, right? And it's going to add to more disuse, more disability, more depression, and we kind of get stuck in that cycle, right? So this is where we can get stuck in the nociplastic range. And again, once we're there, it's really tough to get out. With some of that just pain neuroscience in the background, it's going to relate to just general anatomy and the way that we treat it. Some of these conditions like disc herniations or radiculopathy, where you're having nerve issues going all the way down the arm or leg, whether it be burning, pain, numbness, tingling, you're already kind of being put into that neuropathic pain just from that injury, right? You could have a crush injury of the hand, have peripheral nerve damage. We'll talk a little bit in a second about the difference between compression and sensitivity, right? If you have actual nerve damage, you may be stuck with that, but if it's sensitivity, there's a lot that we could work with that rather than going into surgery right away. Meniscus injury, again, we kind of talked about those Pacinian corpuscles. It takes a lot to elicit that system and to get feedback, right? So unless you, let's say, tear a meniscus, it's kind of hard to feel it until you've gone through the meniscus, right? And then if you go in and kind of break through that cartilage layer, a lot of times that's where we start to kick in other mechanoreceptors, where then we start to actually have that pain experience. And I'm really looking at this as a knee meniscus injury, arthritis, right? We go through those layers, we're now bone on bone. Easiest thing to treat would be tendonitis, tendinopathy, or strain, as well as a ligamentous sprain, right? Dealing with more of the mechanoreceptors, Golgi tendon apparatuses, and muscle spindles, right? There are times that we can load the tendon. That's what the tendon actually needs to repair, right? If we have an injury, we may need to go through a healing time. There are things to help with that healing time. And then we actually need to load the tendon, right? Most injuries take about 6 to 8 weeks to heal and be stabilized, where then we can actually start importing some different treatments to you as far as loading goes, right? There are plenty of other things to do to manage pain and just help with range of motion, like modalities, manual therapy, gentle exercises, which we'll talk about in a second. All right, I kind of threw concussion in. Maybe a little misnomer of orthopedic, but we see it in the outpatient world quite a bit. Some of these injuries that I talked about, you talked about like ion changes, right? So we have changes in calcium channels, sodium channels, potassium channels, right? A lot of people say, well, should I go out and get vitamins and take a bunch of vitamins? Well, certainly doesn't work like that. What's happening is it's a regulation issue of the body, right? So for any of these injuries, even for concussion, it's a regulation injury of the body. You may have actual chemical changes, right? If you have a bruise, and concussion is kind of a brain bruise, you're having a physiological response so that your body can try to heal itself. It creates problems though while it's doing that, because we can start to have swelling. We have inflammatory markers that get into there, cytokines, prostaglandins. There's all kinds of things. I'm not going to get into the weeds of what's going on the cellular level, but just to give you some clue is, the pain is going to sometimes cause these different changes, the physiological changes. If we're looking at tendonitis or tendinopathy, is it that there's a lot of swelling and it's actually congested in the area, we need to pump it out? Or is it we haven't been using it because it's been painful and it's actually dried out, it's dehydrated, we actually need to get some blood flow into the area, right? With concussion, for instance, we need to get oxygen and blood flow to the brain so that it can restore itself. And then here comes the fun stuff, the weird pain stuff. Right, fibromyalgia is a big one, chronic fatigue, complex regional pain syndrome. A lot of times these will go hand in hand. Again, these can turn into, immune responses. We can start to get into like rheumatoid issues at that point. But there's a lot that we can do as far as these different conditions that I'm going to get into in a little bit as far as treatment goes. People are more disposed to fibromyalgia. There's actually some research being put out that there's some extra nerves within the body that the person's able to then experience or have sensitivity to pain. It's going to predispose you to it. I threw in frozen shoulder and adhesive capsulitis are the same. I threw these in just because there's a little bit of an anomaly with that condition. We see it in the orthopedic world a whole bunch, but is it coming from an orthopedic standpoint? I had mentioned the enteric system, right? The nervous system. So is it coming from the gut? Is it coming from more of a systemic issue? We're finding within the research that we do have, and I'm sure that we need more. We don't have everything uncovered, but we're seeing that the body attacks itself, right? On a physiological standpoint. We're seeing inflammatory markers within the blood, that are affecting that joint, affecting the shoulder. And eventually, it initially goes from that, heightened inflammation process to then a fibrotic process. We see a morphological change within the tissue and actually creates a fibrotic capsule, right? Which locks down. Then over time, it just thaws out. It's a little bit of an anomaly. Some people just wake up with it. Some people have an injury and they're predisposed to it. But yeah, kind of an anomaly and certainly a different one. Polyvagal, there's the vagal nerve or vagus nerve, which is a cranial nerve. And this nerve goes from the brain, supplies the heart, lungs, the gut. So there's a polyvagal theory out there, just instead of like injuries, just that saliency aspect, right? How has our experiences shaped ourselves and how do we deal with things on a day-to-day basis? So they're kind of looking at a ventral vagal cycle, which is kind of like your safety net. There's the sympathetic response. I mentioned the sympathetic response before. That's kind of your fight and flight, right? So like I'm getting in my car, I feel safe, I feel great. I'm driving down the road and then there's sirens behind me, right? What's going on? Sympathetic nervous system's going to go off, right? Then the last one is a dorsal vagal component. And this is a kind of a incapacitation, a shutdown, right? So if you've had experiences in your past, maybe you were bullied or something like that, that you felt hopeless or helpless, a lot of times the body will shut down, right? So these three different saliencies or senses or emotional states, right, are going to either help you or impede you with dealing with pain. And we find that people really get stuck within the sympathetic level or that shutdown level. We can actually stimulate the vagus nerve. And I know that there's companies out there, there's products being put out now. I don't know the efficacy on them. I don't know if they're helpful or if they work or not. I've been seeing a lot more commercials and things for them. But for example, we can stimulate a little bit of the vagal nerve through the neck. I have a patient right now. She's got weird widespread pain all over. She's certainly in that shutdown state. I get her on the table, I lie her down on her back and just work a little bit on her neck. You can see her whole body will reset. She pops up from the table with a big smile on her face, right? So it's interesting. It's certainly beyond an orthopedic condition, right? It's there's something going on within the entire state of the body that's completely thrown off. And again, a lot of this is due to, traumatic experiences or just, negative experiences or maladaptive coping mechanisms that have now shaped itself. So how can we help? What can we do? Do we do surgery? Do we do medications? I threw a couple studies in here. One is on basically there was a shoulder impingement systematic review. They did either surgical with physical therapy or they just did physical therapy alone. And here's the conclusion from that result, from that test, right? It's too small clinically to see at 3 months, 6 months, a year out, 2, 5, 10 years out, right? So they didn't see a big difference between surgery and therapy and just therapy alone. Now, look, if you're at a point where you need a joint replacement, you need a joint replacement. If you have a torn rotator cuff, we can't fix that, right? We can work around it. We can work on other things, but I can't actually repair the joint. I can't repair the tendon, right? So surgery is effective in that sense. Certainly surgery has its time and place, but for things like I had mentioned, sensitive nerve, I have a lot of people that will jump for surgery. They're no better after surgery. If anything, they might be even worse, right? Because you're creating a trauma, you're creating more inflammation, right? They need more so neurodynamic mobilization and therapy rather than surgery, right? But if you have something like a disc herniation, you have a compressed nerve, there's a bone spur that's sitting on that nerve that just, it's not going to decompress, it's not going to lift. Certainly surgery is an option, right? I would say as a last resort. I also threw in just a little study on the use of opioids. What's going on with opioids? Well, really, they're blocking your pain receptors, right? They're creating that Band-Aid. Pain cannot get through to the brain. We talked about, going up through the A delta and C fibers, going up to the brain. It just blocks that pathway. And a lot of it actually has to do with that vagal nerve, the vagus nerve. And it actually depresses the lungs, right? So if we're looking at pain, I mentioned pain will heighten up, right? It will make you have short, shallow breaths, which then is not very good for blood flow. It doesn't get blood flow moving. It doesn't get inflammation moving. It creates stagnation and pulling, right? So in a sense, the opioids are going to kind of help out the parasympathetic nervous system. I had mentioned sympathetic, which is heightening up, fight or flight. Parasympathetic is calming down, rest and restore, relaxation. So evidence base, as you can see, not much better out 12 months out. We're actually seeing more in the research. There's a ceiling effect around 3 to 6 months. Opioids certainly have their time and place, like I had mentioned, for a lot of these different treatments, right? The problem is, though, with opioids, there can be more harm than good. We find that this is very addictive because to continue blocking those receptors, you may need more, right? You may build a tolerance to it. You may even then start to build a dependence to it because now your nervous system, we call it neuroplasticity, it's created a new norm in the brain, right? It's created that synapse that comes closer and closer together, and that's the signal that needs to fire first, right? So we find that with opioids, the person may be saying, I have 7 out of 10 pain. And then 3 to 6 months out, they're still taking the opioids. They're still at a 7 out of 10 pain. Right? But they might tell the doc, but I can't take myself off the medication. Like, I feel better on it, but you're telling me you're still at a 7 out of 10 pain. Yes, but I'm better. So it doesn't make sense, right? It's creating a new norm in the brain. It's giving that feeling that it's working. At that point, it's really just creating a new norm. So how can we help? What are some tools to the trade? All right, if surgery is not the option, if medication is not going to be super, super helpful for you, what can we do? Well, as far as with psychologically informed therapy, this is really good for that neuropathic and nociplastic pain. There are certain things out there. We are not psychologists, right? So we're mostly physical therapy, occupational therapy, and speech, but we're going to be blending a lot of those same techniques to help you with treating your brain and your body because we have to do both. So there are a couple things out there. I just gave you some examples of pain reprocessing. Um, and that's literally what it is. It's almost reprocessing your brain around what pain is and what you're experiencing. Let's say there's an activity. So for example, my carpenter trying to screw whatever he was screwing in. Maybe he needs graded exposure to those tasks. Maybe he needs those tasks broken down. See if there's a biomechanical issue with that. Is there something that the body is not doing correctly, or are you just perceiving pain? Right. And so then we can help to talk through that and work through that. Cognitive behavioral therapy is also kind of similar, right? Or can we use imagery? Can we talk about experiences and blend them so that you can get through the mission, right? So I had talked about the room being on fire. If your dog is, let's say in that building, you're most likely going to go back in for the dog and get him out. And again, with that mission intent, you may not feel all of that heat on you, right? So if we can lock in mentally into the activity that we're doing, it's very, very beneficial for getting through painful activities. Modalities in manual therapy are very similar. I had kind of given you that picture before. I guess I can swoop all the way back. All right, but modalities and manual therapy are going to help with stimulating those mechanoreceptors, right? So we talked about the delta C fibers. These are carrying pain. Well, we have baby fibers, right? So if we're giving some kind of input to the brain, whether it be modalities, heat, ice, electric stimulation, ultrasound, diathermy, laser, or manual therapy, just massage or some joint mobilization, decompression of the spine. It's going to help to stimulate those mechanoreceptors, which is a good feedback to the brain. And if we can empower the body with more of a good feeling than a bad feeling, well, then good's going to win out, right? That's the gate theory right there. So it kind of will help to break that pain cycle because your brain is now having to process two different types of stimuli, right? And one being actually a good stimuli. It really, really helps to get that brain past that. There's obviously a lot more complex discussion on how these things work. So if you guys want to talk about it in the discussion, I have a 3-page single space explanation on manual therapy and how that is helpful on a cellular level, but I'll save that for the end if you're really interested. Therapeutic exercise, aerobic conditioning is a big one. So I had mentioned things like complex regional pain syndrome, fibromyalgia. There's a ton of research on the aerobic conditioning aspect being really helpful, right? So like for fibro, for instance, we find that long duration, low intensity is usually best for people. A lot of times they don't do well with manual therapy, especially deep pressure, trigger point release, because the nervous system is so heightened at this point. When we're looking at therapeutic exercises and aerobic conditioning, if we're working within 45% to an 85% heart rate max, we're really getting this fluid dynamics going. We find that within 15, 20 minutes, especially up to 30 minutes, we have a release. We have a chemical release from the brain. It's called endorphins. It's an endogenous or within your body opioid. It's a natural painkiller, right? So people do very, very well with this type of exercise. Arthritis is a big one. Actually, motion is lotion, right? So if I can get somebody on a bike for 20 or 30 minutes, they're going to feel a heck of a lot better because of these physiological responses and chemical responses within the brain. And then into the body. The only problem is that output, right? So if there's a maladaptive coping mechanism going on, if there's a disruption within the brain that's going on, and you're getting basically a relay from top down that's bad, a lot of times you'll start to see people having pain with certain movements that they really shouldn't be. We know then very quickly that we need to implement different techniques. And a lot of times it's these other ones down here, right? So I had mentioned once you have pain, everything locks up, diaphragmatic breathing techniques, that meditation, super, super helpful for getting things moving, getting that lymphatic drainage throughout your body, kind of clearing the sludge within our body. And 70 to 80% of that is within the gut. All right, the diaphragm is going to lift and control that gut, lift your ribs, really get your blood flow going. All right, so if we can elicit diaphragmatic breathing, really focus on the breath, long duration breaths, it's going to help stimulate the parasympathetic nervous system to help rest and restore and calm things down. All right. The other thing that we can implement is progressive muscle relaxation techniques. If you were to Google that, you'll find a whole bunch of stuff on that. Again, this is kind of a meditative, kind of a contract, relax type of technique for your muscles. It's a whole body implementation. I should have matched it with sleep hygiene education. This one's awesome to do right before bed. It's very, very relaxing. Again, it's going to really elicit that parasympathetic nervous system and get things to calm down. Nutrition is a huge one. Just look at the back of what what box you're holding, what container you're holding, and see if you can actually pronounce some of the ingredients in there. Right. So nutrition is a huge one. There's a ton of food and drinks that we're putting into our bodies that are very, very inflammatory, and that are really going to have negative effects to our nervous system. It's also going to affect our sleep. Sleep is a big one when we're in pain, especially chronic pain. A lot of times people are not sleeping very well. Is it due to just pain and they're having a bad night, or is it maladaptive coping mechanisms? Are there some suggestions that we can give? So there's a whole list, a whole task force of ideas for sleep hygiene. Winding down an hour before bed, not eating chocolates, obviously caffeine, not having any of that, getting your TV out of your room, and then setting a clock, same time every night, go to bed at 10, or wake up at 6 every day, and try to keep to that time frame. All right, so these are just some tools of the trade. The biggest ones I would say are going to be your therapeutic exercise and aerobic conditioning, manual therapy, and then modalities as well as these other integrative techniques.